Friends, MR Fistulogram is one such investigation you will encounter day in and day out as a radiologist. And you know what? Every time you report, you will face some new difficulties. Sometimes you will overwrite it, sometimes you will underreport it because the base is not clear. You don't have the base upon which you can build the building. So in this session, I tried to discuss the basic points of MR Fistulogram, and I made a structured report. What are the relevant information you need to incorporate in your report? And I promise you, if you listen to this session for next 20 or 25 minutes with lot of positivity, I bet you can report MR Fistulogram independently even if you are first year resident, because the base will be clear and the relevant points will be clear to you. And as I promised before in the trailer of the IRAD, this will be more like a casual conversation, education with fun. So listen to the session with empty mind, just sit and relax, enjoy the session. This is the easiest topic, just sit and enjoy. As I promised before, this will be a radiology podcast. Hello friends, how are you? Hope you all are doing good. I am Dr. Raman Sau and my topic of discussion is MR Fistulogram. Well, first of all, we will have a look at the anatomy of the perianal region. Then we will discuss the different types of fistulas, how they look in MRI, and we will try to make a structured report format for MR Fistulogram. Well, let's take the anatomy of the perianal region first. Perianal region is formed by two sphincters, internal anal sphincter and external anal sphincter. We will discuss with the help of an image. Now, as you can see, this is rectum. Down the line, this is anal canal. And somewhere between these two is the anorectal junction. Above the anorectal junction is rectum, and inferior to the anorectal junction is the anal canal. Okay. And as you can see, this is the internal anal sphincter. This is internal anal sphincter. And internal anal sphincter is formed by the muscular layer of the anal canal itself. This is an involuntary muscle. Whereas the external anal sphincter, I have marked the sphincter. External anal sphincter is comprised of three parts. As you can see, this is one part, second part and third part. Upper, mid and lower. Upper part also called as the deep part. The middle part is also known as the superficial part, and the inferior most part is the subcutaneous part. The upper part of the external anal sphincter, it has a relation with puborectalis muscle. Some fibers of the deep part of this external anal sphincter, it blends with the puborectalis muscle. External anal sphincter is voluntary muscle, and this is the pelvic diaphragm, the levator ani muscle. See, the very important muscle. This is levator ani muscle, also known as the pelvic diaphragm. And the yellow colored, the space, this is ischiorectal fossa or ischioanal fossa. Let's jump on to the next image. This is a better image, I would say, zoomed image. You can see the internal anal sphincter. This is the internal anal sphincter, and this is formed by the muscular layer of the anal canal itself. And you can see this is the continuation of the rectal muscle also, rectal muscular layer also. And this is the external anal sphincter, three parts. This is the deep part, superficial and subcutaneous. As I told before, deep part of the external anal sphincter, it blends with the puborectalis muscle. The interesting part is the space in between these two, the sphincter is known as intersphincteric space. Very important space, because the most common type of fistula, it happens in this space. This is the space. This is the intersphincteric space, and that's levator ani, and lateral to this is the ischiorectal fossa. This is the axial image of the perianal region, and I'll change the color. This is the internal anal sphincter encircling the anal canal, and that's external anal sphincter. So this is internal anal sphincter, and that's external sphincter. The space In between these two is the intersphincteric space. Okay, so in axial image, that's intersphincteric space in between IAS and EAS, internal anal sphincter and external anal sphincter. And as I told before, the upper part of the deep part of the external anal sphincter, it blends with puborectalis muscle. See this? This is the external anal sphincter and it is blending with the puborectalis. Pubo, because this is pubic bone, and rectalis, I mean puborectalis or puboanalis, whatever you can say. This is the anal canal, and so pubo and rectal, puborectalis muscle. Okay, clear? Now we will have a look at the MRI image, the same image. It was schematic before, and we will have a look at the original picture in MRI. Well, see this. This is the anal canal. Well, the sky color is the anal canal, and the deep blue color is the internal anal sphincter, and this is the external anal sphincter. And the area in between these two, internal anal sphincter and external anal sphincter, is intersphincteric space. So in the axial section, if you see a intersphincteric fistula, it will be somewhere in between these two. Okay, another image of the axial section, the upper part of the external anal sphincter is, it blends with the puborectalis muscle. You can see clearly, this is the puborectalis muscle, and this is external anal sphincter, and this is the coronal image, very clearly seen. This image, or rather this image, and you compare this with the coronal image on MRI, very clearly seen. Okay, so this is the internal anal sphincter, and that's levator ani, and this is external anal sphincter. You can see the three parts of external anal sphincter also, right? And this is intersphincteric space, and lateral to the external anal sphincter is the ischiorectal fossa or ischioanal fossa. So this area is ischiorectal fossa. Whenever we get a fistula on MRI, where the internal opening is situated, it is determined by a clock, what is called as anal clock. Now have a look. This is the anal clock. The patient is in lithotomy position. Assume that you are doing TVS, so that position is lithotomy position. And this is 12 o'clock, 6 o'clock. So 12 o'clock is anterior, patient's anterior. 6 o'clock is posterior. 3 o'clock is left side, left lateral, and 9 o'clock will be right lateral. So this is right side of the patient, left side, anterior and posterior. Now I'll ask you a silly question. Do you know the difference between a sinus and a fistula? What is a sinus tract and what is fistulous tract? Well, a sinus tract is a blind ending tract where one end is blind. Okay, see this? One end is blind. Whereas a fistulous tract is, there is a communication on both sides. It can be a internal fistula and it can be a external fistula. When the fistula is happening inside your body from one hollow viscus to another hollow viscus, this is internal fistula. And when the fistula is happening from a hollow viscus to the exterior, to the skin, like in this case, in perianal fistula, from anal canal, a hollow viscus to the exterior, to the skin, this is external fistula. Now we know the anatomy of the perianal region. We also know the MRI anatomy of the perianal region. We know what is fistula. We know the difference between a fistula and a sinus. Now we will learn the Goodsell's rule, widely popular rule. I think we read it in final year MBBS, right? So Goodsell says that, first of all, draw a anal clock, 12 o'clock, 6, 3, 9. 12 o'clock is the anterior, 6 is the posterior, like in lithotomy position, and this is the anal canal, and draw a imaginary horizontal line from 3 to 9 end, horizontal imaginary line. And Goodsell says that if the internal opening is anterior to the horizontal imaginary line, towards 12 o'clock position, इधर अगर होगा internal opening, then the fistulous tract will be simple, radial and straight. For example, if this is the internal opening, the course will be like this. Okay. But if the opening is posterior, if the internal opening is posterior, it will have a more complex course and curvilinear course, and it drains into the strictly at the midline at 6 o'clock position. For example, if this is the fistulous tract, this will come and drains at 6 o'clock. This side also it will drain at 6 o'clock. So anterior to the imaginary line, it will have a more simple, short and radial course, whereas posterior to the horizontal imaginary line, it will have a complex curvilinear course and it will drain at the midline. And now I think we are ready to see the different types of fistula. We are ready to take the challenges. Let's look at the schematic images first. There are two types of classification. One is surgical classification and another is radiological classification. हमेशा की तरह सर्जरी और रेडियोलॉजी के बीच में यहाँ भी मतलब there is some confusions. So surgical classification is simple, basically 4 types of fistula: intersphincteric, transsphincteric, suprasphincteric, extrasphincteric. This is known as Parkes classification. So have a look at the image. So intersphincteric fistula, this is the commonest fistula. Nearly 70 or 70, I think 70% of the fistula is intersphincteric. In this case, a fistulous tract, it starts from the anal canal, it crosses the internal anal sphincter, and then it comes into the intersphincteric space, and after crossing the intersphincteric space, it drains at the skin. See this? Now the second type of fistula, transsphincteric. In transsphincteric fistula, the fistulous tract, it starts from the anal canal again, it crosses the internal anal sphincter, then it crosses the intersphincteric space also, and it pierces the external anal sphincter. It drains at the skin after traversing the ischiorectal fossa. So in transsphincteric fistula, it pierces both the sphincters, internal and external, whereas in intersphincteric fistula, it pierces the internal sphincter only. And this is 70%, and transsphincteric fistula is 25%. And among these two, type 1 and type 2, 95 fistula are these two types only. Now come to the third type of the fistula, what is called as the suprasphincteric fistula. In suprasphincteric fistula, like any other fistula, it originates from the anal canal, then it pierces the internal sphincter, it traverses through the intersphincteric space, but it courses upward. That is why supra. So it courses upward above the external sphincter, then it pierces the levator ani, and then it courses downwards to end at the exterior, at the skin. So in suprasphincteric fistula, it is not involving the external sphincter, it is only involving the internal sphincter. It is coursing above the external sphincter, and it pierces the levator ani muscle. Whereas in the fourth type of the fistula, what is known as the extrasphincteric fistula, one end is at the rectum. Very big difference. In other types of the fistula, the hollow viscous end is at the anal canal, whereas in extrasphincteric type, the end is at the rectum. It is coming from the rectum, then it pierces the levator ani, then it courses through the ischiorectal fossa to end at the skin. So 4 types of fistula: intersphincteric through the, see at the image, through the intersphincteric space, and it does not cross the external sphincter, whereas in transsphincteric, both the sphincter is crossed by the fistulous tract. In suprasphincteric, it courses above the external sphincter and pierces the levator ani, and it comes down. And in extrasphincteric type, it ends at the rectum. It is coming from the rectum. So suprasphincteric and extrasphincteric, what is the difference? In extrasphincteric, one side of the blind end is coming from the rectum, okay, whereas in suprasphincteric, it is coming from the anal canal, right? This is a fresh image. We will try to draw the same 4 types of the fistulas again in short, so revision bhi ho jayega. So this is intersphincteric fistula, this is transsphincteric fistula, this is suprasphincteric fistula, and this is extrasphincteric fistula. All clear? So this is the Parkes classification. Intersphincteric is 70%, transsphincteric is 25%, suprasphincteric 5%, and extrasphincteric is the least common type, 1%. So majority of the fistulas are basically intersphincteric and transsphincteric. 95% of the fistulas are inter or transsphincteric. Now let's come to the radiological classification. As always, radiological classifications are a bit complex and difficult than the surgical ones. So radiological classification, basically we are accounting the abscess formation and ramification into the Parkes classification. So the grade 1 is simple intersphincteric fistula, like previously, simple linear intersphincteric fistula. Grade 2 is grade 1 plus abscess or secondary tract or ramification is, if ramification is there, then it is grade 2. And grade 3 is transsphincteric, crossing both the sphincters. Grade 4 is transsphincteric plus abscess or secondary tract. And grade 5 is supralevator or translevator extension. It is crossing the the levator ani. So grade 1 is simple intersphincteric, grade 2 is intersphincteric plus abscess or ramification, grade 3 is transsphincteric, grade 4 is transsphincteric plus minus abscess or plus minus not plus abscess or ramification, and grade 5 is translevator or supralevator extension. The fistulous tract is piercing the levator ani muscle. Now we will discuss about the most important part of our discussion, which is how to report a MR fistulogram effectively. क्या चीज़ मेंशन करना पड़ेगा, पॉजिटिव फाइंडिंग्स, नेगेटिव फाइंडिंग्स, व्हाट आर द थिंग्स वी शुड मेंशन इन आवर रिपोर्ट. You can do the grading of the report, but the surgeon, they don't understand the gradings. They ask for the मतलब क्या है बता दो, बस क्या है बता दो. They don't understand the grading, they don't remember the grading rather. Some 4-5 important point definitely you should mention in your report. It is present or not, it should be mentioned in your report. Now first is definitely type of the fistula. What is the type? Intersphincteric, transsphincteric, suprasphincteric. So you mention the type of the fistula. Second is the internal opening according to the anal clock, 8 o'clock, at 1 o'clock, at 3 o'clock, whatever is the internal opening, you definitely mention the internal opening. Now number 3 is if there is any ramification present or not. Ramification means branching tract. You are seeing the main tract, and opposite side there is a branching tract. You should mention that a branching tract is present and mention the position. And if no branching tract is present, you should mention in your report that no ramification or branching tract is present. So ramification. Fourth is abscess formation. Again, abscess formation is there or not. If also it is not present, definitely you should mention in your report that no abscess formation is seen. The negative finding is also important. And now length of the fistula, and the length is measured in coronal image. So in coronal image you should mention that what is the distance from the skin to the the internal opening, the length of the fistula tract. So length in coronal T2 or STIR, whatever you are comfortable with. And number 6 is again very, very important. You should mention that the tract is active tract or fibrous tract. Well, how do you differentiate it? Active tract is hyper in T2 and STIR, whereas fibrous tract is hypo in T2. Okay, so hypo in T2. And if you give contrast, the active tract will show peripheral contrast enhancement. The tract is filled up with pus, it will not show any enhancement, but the wall of the tract, it will show enhancement. So peripheral contrast enhancement in active tract. And if it is filled up with granulation tissue, the granulation tissue, it shows brilliant contrast enhancement, whereas in fibrous tract it will not show any enhancement, or if at all it is very mild enhancement. Now let's quickly have a look on the MRI images. You tell me what is the type of the fistula. Now can you see the fistulous tract? And this is intersphincteric fistula, because This is the external sphincter and this is the internal sphincter. The fistula tract is in between the internal and external sphincter. So this is intersphincteric fistula, simple intersphincteric fistula. There is no ramification and it is hyper in T2. So active tract. If you follow the format, type is intersphincteric, opening, see where it is the opening, maybe 9 o'clock. Ramification, no. Abscess, no. Length in coronal for say 3.8 centimeter. Active or fibrous, active tract, right? So number 1 image, we are done with this image. Now let's come to the number 2 image. Can you see? Well, in this image you can see the ramification. This is the main, this is the ramification and this is the main fistula tract. So ramification is present. Again it is intersphincteric fistula, but ramification is present. Mention it, and it's a active tract because it is hyper in T2. So active tract, no abscess formation, but ramification is present and intersphincteric fistula. I think you are able to answer this, right? So now can you answer this? Where is the fistula? This is the fistula. Well, it is not fistula, rather it is abscess. Okay, let's look at the coronal images. This is the coronal image. See this, it is filled up with lot of pus inside the tract, and lot of edema is also seen in this tear image, lot of edema. And in coronal image, can you see it is coursing above the levator ani. This is the levator ani and it is above the levator ani muscle. So supralevator extension is there and ischiorectal abscess formation is there. Okay, so it's a complex fistula, right? Now the next image. In this image, can you see the fistula tract is hypo here, hypo in T2. So this again intersphincteric fistula, simple. Mention the internal clock position, internal opening, length of the fistula, blah blah blah, whatever I mentioned in the format. You mention one by one. But in 6th number position, active or fibrous, this is fibrous tract because it is hypo in T2. See this is hypo in T2, whereas if you compare this with this image, this is hyper. So hyper is active tract, hypo is fibrous tract or heel tract. Now the next one. Well, this is the fat suppressed or steer image. Okay, interesting. This is transsphincteric. Can you see it is traversing the internal as well as the external sphincter? This is external sphincter, right? So it is crossing the external sphincter. You can clearly see in coronal images. This is the coronal image and it is clearly crossing the external sphincter. I will try to label it. This is coming from the inside of the anal canal, crossing the external sphincter also. And important point is, again this is heel tract or so called the fibrous tract because it is hypo in T2 again. So hypo in T2, this is transsphincteric. Transsphincteric fistula, simple transsphincteric fistula and fibrous. This is fibrous. So I'm nearly done with my discussion. Let's have a quick brush up. This is the perianal region anatomy, internal sphincter, external sphincter, the intersphincteric space, internal sphincter, this is external sphincter, in between two is the intersphincteric space, this is levator muscle and the 3 part of the external sphincter. Okay, so and the deep part of the external sphincter, it blends with the puborectalis muscle as I said before. This is the axial image. Anal canal, encircling the anal canal is the internal anal sphincter and outer to this internal sphincter is the external sphincter and the space in between these two is the intersphincteric space. Okay, so this is the MRI anatomy, again the same coronal image of the MRI. Levator ani is the muscle, this is the levator ani, external sphincter and internal sphincter. The space in between these two is the intersphincteric space. So this is the anal clock. Okay, sinus is blind-ended, whereas fistula, both end is communicating. Good cells rules. I told you before. Different types of the fistula. intersphincteric, transsphincteric, suprasphincteric, extrasphincteric. This is the surgical classification. Okay, intersphincteric and transsphincteric, they comprises of the 95%, and most of the fistula is in these two types only. And radiological classification, what is called as the St. James classification. Grade 1 is simple linear intersphincteric, grade 2 is grade 1 plus ramification or abscess, grade 3 is transsphincteric fistula, grade 4 is transsphincteric plus ramification or abscess, and grade 5 is supralevator or translevator extension. I formed a format of reporting where 6 important points should be mentioned. First is the type of the fistula, second is the internal opening, then ramification present or not. If it is not present, just don't avoid it. Mention in your report that no ramification is present, no abscess is present. Mention the length of the fistula in coronal image. Also mention if the tract is active or fibrous. Active tract will be hyper in T2, whereas fibrous tract will be hypo in T2. I showed you the different types of the images. This is the active tract again, intersphincteric, simple. This is intersphincteric fistula, but ramification is present. See, two horn is present. So one is the main and another is the branching tracts, and intersphincteric also. And next type, this is the big abscess formation, and it is crossing the levator ani. So supralevator extension is there, and this is intersphincteric, but as it is hypo in T2, so this is fibrous tract. Okay, again fibrous tract because it is hypo in T2, but this time it is transsphincteric fistula. It is crossing the external sphincter also. See, this is crossing the external sphincter. So I am done with my discussion. I think I have cleared your doubt a bit, if not more. And still, if there is any query or any confusion, you can contact me in my mail ID and in different social media handles. I'll give the links or so-called the handle name. You can contact me. Take care. And many congratulations পুরো আইরেডের টিমকে, সরণদা, কৃষ্ণেন্দুদা আর যারা যারা আছো সবাইকে থ্যাংক ইউ জানাই ফর গিভিং মি দ্য অপরচুনিটি টু প্রেজেন্ট মাই টপিক। আর এত বড় একটা কনফারেন্স নিজেদের মধ্যে অর্গানাইজ করা ইজ নট এ ম্যাটার অফ জোক। আর সরি ফ্রম মাই সাইড ফর নট বিং প্রেজেন্ট দেয়ার। লাস্ট টাইম আই ওয়েন্ট দেয়ার অ্যান্ড আই হ্যাড এ গ্রেট টাইম, আই হ্যাড এ ব্লাস্ট। সবাই এনজয় করো কনফারেন্স। পড়াশুনো শিক্ষা ক্যাজুয়াল ওয়েতে যেটা হওয়া যায়, দ্যাট ইজ দ্য মোটো অফ আওয়ার টিম অফ আইরেড, রাইট? সো এটাকে আমরা মেনটেন রাখবো, কোনো ওই ভেদাভেদ রাখবো না, জুনিয়র সিনিয়র এইসব মিলে ওরকম কোনো যেন ওই একটা ব্যারিয়ার না থাকে। সো দের ইজ এ ফেমাস কোড না, ডু নট মেক ওয়ালস ইন বিটুইন, মেক ব্রিজেস। হ্যাভ এ ব্লাস্ট। দেখা হচ্ছে নেক্সট কনফারেন্সে।